Today we will see on approach to a management of measles. We can clinically define measles if a patient is having fever of more than 38.3 and cough, coryza or conjunctivitis and a generalized maculopapular rash lasting 3 days or more. The clinical picture of measles can be divided into 3 stages: prodromal, eruptive and convalescent. It should be suspected in patients with the classic triad of the 3 C's: cough, conjunctivitis and coryza. So a laboratory criteria for diagnosis of measles is 4 times increase in antibody titer, isolation of measles virus or presence of IgM antibodies. When we came to management of measles, any patient with confirmed measles or symptoms suspicious for measles, first we should have to mask a patient and other persons such as caregiver and the siblings. We should have to isolate in an airborne infection isolation room. Airborne infection isolation room. If airborne infection isolation room is not available, isolate in a private room with door closed. Patient and others in that room should remain masked and order airborne precautions. Everybody in the room and in that area should have to have airborne precautions. After isolation, obtain strain and perform exam. Ask about vaccine status, specifically about measles. Ask about contact history or exposure. Period of contagiousness is 5 days before appearance of rash to 4 days afterward. And the incubation period is around 6 to 21 days with average of 2 weeks. Ask about signs and symptoms include date of rash onset, any history of fever before the onset of rash, any signs and symptoms of coryza, conjunctivitis. Check vital signs, check aeration status and respiratory status. Consider also alternate etiologies if there is other illness that explains the problem other than measles. And then assess level of illness. Assessing level of illness is important on the management of a child. We assess severity of illness as mild, moderate, and severe. We say mild measles if there is no respiratory distress or oxygen requirement and able to self-hydrate. We say moderate if they require ongoing IV fluid support or require respiratory support, including low flow nasal cannula for hypoxia and high flow nasal cannula for increased work of breathing. We say severe and complicated measles if there is hypoxia or work of breathing requirement, which requires non-invasive or invasive ventilation, or concerns that patient status is worsening on high flow nasal cannula, or if there is sepsis, shock, or rapidly worsening. Management is based on the severity of the illness. For mild symptomatic case that doesn't need hospitalization for support, obtain basic labs such as CBC and CRP and investigations to rule out other possible infectious disease that explains the problem. Give vitamin A, evaluate and treat suspected co-infection based on symptoms, discuss with parent and the caregiver the need for exclusion from school or daycare for other household members who have not received the vaccine. For moderate and severe signs and symptoms that require hospital admission, check CBC and the CRP and do other investigation to rule out either complication or rule out other possible differential diagnosis. Give vitamin A. Hydrate with eye fluids if indicated, or consider NG2 if oral lesion prevent PO intake. Take 2-view chest X-ray for respiratory symptoms to evaluate for infiltrate and evaluate and treat suspected co-infection per symptoms. Antibiotics per suspected sepsis order set if sepsis is present. Let's see acute complications from measles. If a fever persists beyond the 3rd or 4th day of rash, this may suggest a measles-associated complication. Complication can be GI. GI complications such as diarrhea and stomatitis are common, and this may lead to poor PO and dehydration, PO intake, and the vomiting also occurs sometimes. In CNS, encephalitis, which occurs around day 5, and acute disseminated encephalomyelitis may occur around 2 weeks. ENT and respiratory complications include otitis media, tracheitis, croup, and respiratory distress. They are well described, and the Measles pneumonia might cause symptoms and radiographic findings that overlap with bacterial pneumonia. However, co-infection may occur, including strep pneumonia, strep pyogenes, H. influenza, Staph aureus, and the virus. So use antibiotics if strong suspicion for a pneumonic bacterial process due to clinical exam and imaging findings suggests uh, bacterial superinfection. Chest X-ray findings for measles include mixed reticular opacity, airspace consolidation, and hilar lymph node enlargement. Ophthalmology complications include purulent conjunctivitis, keratitis, xerophthalmia, which is a risk for blindness due to vitamin A deficiency, evaluate for pain, photophobia, erosion, or opacity. Vitamin A is recommended for all patients with measles for less than 6 months, 50,000 daily for 2 days. From 6 to 11 months, 100,000 daily for 2 days. And for more than 1 year, 200,000 international units daily for 2 days. If severe malnutrition or high evidence of vitamin A deficiency is present, administer a third dose 2 to 4 weeks after the second dose. Treatment recommendations for pneumonia, which is felt to have bacterial component, include for less than 28 days, use ampicillin plus cefotaxime. For more than 28 days, use ceftriaxone. And consider adding azithromycin for patients greater than 5 years. Antibiotics per suspected sepsis or death if sepsis is present. Thank you for watching.